Thank you to the ANZ Society of Nuclear Medicine for inviting me to speak on behalf of my co-authors to our paper entitled Empiric radioiodine for hyperthyroidism, Outcomes, Prescribing Patterns and its Place in the Modern Era of Theranostics. To start with some background, I-131 treatment of hyperthyroidism is a beautiful example of classical nuclear medicine, and we've got over 80 years of experience with this. There is, however, no consensus as to the best approach, with fixed, empiric and dosimetric approaches described. Turning to the local literature, high fixed activities have been prescribed for all etiologies of hyperthyroidism, with relatively high success rates of approximately 80% to achieve remission of hyperthyroidism, but a large proportion of these patients are rendered hypothyroid post-treatment. An empiric prescription is more nuanced, with the activity modified based on scintigraphic and clinical characteristics, including gland size, 24-hour radioactive iodine uptake, and desired outcome. And there are multiple guidelines. I've presented the American Thyroid Association guidelines for the ranges for Graves, toxic multinodular goiter, and toxic adenoma here. And finally, a dosimetric approach, which is a more resource-intensive approach aiming to deliver a specific dose in grey to the thyroid tissue to achieve remission of hyperthyroidism and potentially higher rates of euthyroidism, though this is not quite borne out. It involves understanding of the mass of the gland, and this must be determined with ultrasound, as scintigraphic data is certainly not accurate enough for this. We need to specify the absorbed dose in grey to the gland, which is disease-specific and aim-specific. And unfortunately, there is no agreement in the literature as to the correct dose in grey to administer to achieve either euthyroidism or even resolution of hyperthyroidism, with a recent meta-analysis by Topogi et al. In Graves' disease showing published ranges of between 50 and over 407 grays in the literature, with, as you might expect, a dose-response relationship for resolution of hyperthyroidism. The EANM guidelines also provide advice as to the grey targets for toxic multinodular goiter and toxic nodule, though this is by no means agreed upon in the literature. To the bottom of the equation, we have the energy deposited per mass per unit time, which is radioisotope specific, and the residence time, which is patient specific and requires a low dose radioactive iodine study to calculate. So at the Royal Melbourne Hospital, we use dosimetry in our I-131 treatment of thyroid cancer, but take an empirical approach for hyperthyroidism. So we've got a tension in our department between empiric prescription for hyperthyroidism and more rational and theranostic dosimetric principles. So we asked ourselves the question, should our practice change? Our aims of this study, therefore, were to evaluate the outcomes of patients empirically treated with radioactive iodine for hyperthyroidism at our centre, to evaluate factors that influence the efficacy of our prescribed activity, and to identify patients who might benefit from more resource-intensive, rigorous dosimetry. So this was a quality assurance project that involved a retrospective chart review of all patients treated with I-131 for hyperthyroidism between January of 2016 and June of 2021. We reviewed the Charisma database, our electronic medical record, and correspondence from private referrers. We created a standard data collection pro forma to document patient demographics, clinical information, and thyroid scintigraphy results to confirm the diagnosis, as well as ascertain the percentage pectinitate uptake at 20 minutes, which was determined using standard protocols. The outcome that we measured was thyroid status after treatment with I-131, and we defined remission as resolution of hyperthyroidism, either patients rendered euthyroid or hypothyroid after treatment, and persistence was biochemical persistence of hyperthyroidism at follow-up. We did a sub-analysis of our Graves' disease cohort, looking at the absorbed dose in grey response relationship. And here, the equation is a transposition of the MIRD equation I presented earlier, and of note, because we did not have reliable ultrasound data for our Graves' disease cohort, we found a population average from a meta-analysis that we undertook of 5 studies with good sonographically determined gland volume in an iodine-replete Graves' disease population, and applied this to our cohort. And we did a similar approach to determine I-131 residence time. Here are our statistical methods, and we stated a p-value of less than 0.05 for statistical significance. To our results now, over the 5.5-year period, 229 patients were treated at Royal Melbourne for hyperthyroidism, and 146 of these were included in the analysis, with 83 patients excluded due to lack of available follow-up data. Turning to overall demographics, for all etiologies, our success rate or our remission rate was 80.8%. There was no difference in the remission and persistence group in terms of age or sex, and we had similar follow-up times for the remission and persistence group, and of note, a mean of more than 12 months for both groups. In those treated with antithyroid drugs, there was no difference in the mean total daily dose between the groups, nor the cessation parameters. And of note, there was a mean cessation of 5 to 5.5 days in our remission and persistence groups. Although we only had thyroid function tests available for a subset of our patients, what we did find was a significant difference between the groups, with the persistence group having higher free T4 and lower TSH, or more biochemically uncontrolled hyperthyroidism prior to treatment with I-131. In terms of safety, only one of our 146 patients had a flare after I-131 requiring hospital treatment. However, their pre-treatment free T3 was undetectably high, putting them at particular risk. In terms now of scintigraphic parameters broken down by disease etiology, for our Graves' disease cohort, we had a 73.8% success rate, and there was a significant difference between the remission activity prescribed at 375 megabecquerels or 10.1 millicuries, and a lower activity prescribed in our persistence group at 8.8 millicuries. And although it was not statistically significant, there tended to be a higher mean technotate uptake in our persistence group compared to our remission group. We had very high success rates in our toxic nodule group of over 90%, and there was no difference between the groups in terms of uptake or activity prescribed. And finally, our toxic multinodular group did not have a different activity prescribed between the groups. However, there was a higher technotate uptake in the persistent group of 7.3% compared to 2.8% in our remission group. We wanted to look at patients who had very high technotate uptake in a bit more detail. And so we defined very high technotate uptake as over 15%, and each of those 5 patients have a diagnosis of Graves' disease. Now, I presented that our mean activity for remission for Graves' disease was 375 megabecquerels or 10.1 millicuries. And you can see here that 4 of these 5 patients with very high technotate uptake were given below the mean for remission for our centre, and 3 of those 4 patients remained hyperthyroid. Here is an example of a scintigraphy result for the patient with very high technotate uptake at 50%, with very little background and a very intense gland. And so we wondered, were our physicians looking at studies like this and prescribing less activity? And indeed, when we interrogate our prescribed I-131 activity versus 20-minute technotate uptake in our Graves' disease cohort, with technotate uptake shown here on the x-axis and activity administered in megabecquerels on the y-axis, we see a significant negative correlation between higher 20-minute technotate uptake and lower prescribed activity. And so perhaps we have a bias in our department for prescribing lower activity to our Graves' disease populations in particular, for fear of precipitating perhaps a flare of hyperthyroidism or radiation-induced thyroiditis. This, however, might not be entirely rational, as in the literature presented by Somowski et al. In 2016, we can see these graphs with technotate uptake on the x-axis and I-131 at 24-hour uptake on the y-axis, and for a technotate uptake above 10% in a controlled Graves' disease population, there is not a significantly elevated I-131 uptake at 24 hours. And so this fear of precipitating radiation-induced thyroiditis or a flare of Graves with a standard activity prescription at a technotate uptake of over 10% might not actually be entirely rational. So to summarise, at our centre, our empiric prescription of I-131 is effective and safe, with an over 80% remission rate and a very low risk of flare in our cohort. Our Graves' disease cohort results of 73.4% remission with over 200 grey in our sub-analysis is in line with that found in published data. We did find, however, that a high percentage protectate was associated at our centre with low activity prescription below our departmental mean. We think that potentially this is due to a fear of flare, though we know from looking at our data that the risk is low, and we know that this can be mitigated in the right patient with prescription of corticosteroids and beta blockade. The balance must be had of this risk of flare with the real risk of ongoing hyperthyroidism, particularly in cardiovascularly comorbid patients or women of childbearing age hoping to achieve pregnancy. And as I've shown, this fear might not be entirely rational. In our toxic multinodular group, we had a similar activity prescribed between our groups, though the 20-minute protectate uptake was higher in the persistence group, and perhaps this group of patients had reduced I-131 residence time because of very active disease, or perhaps they had larger gland size. We had very high success rates in our solitary toxic nodule group. The limitations of this study include that of our retrospective single centre study design and our small and heterogeneous population. However, our results are similar to local and international studies, improving the generalisability. As I've mentioned, we had a lack of high quality gland mass data, and limitations known and inherent to scintigraphic gland size evaluation, especially in Graves' disease, exist, so we did not include these in the analysis. And then the range of follow-up time might have overestimated remission in some patients or persistence in others. However, our mean for both groups was 12 months. So to conclude, traditional empiric prescription of I-131 is effective and safe for the majority of patients. Resource-intensive dosimetric prescription should be considered in patients with very active hyperthyroidism, though multi-centre studies are required to confirm this. We should also be aware of our tendency to underprescribe, and perhaps our fear of toxic flare looms larger than the actual risk in reality. And finally, the results of this QA project did change practice at the Royal Melbourne Hospital, whereby now 10 millicuries is the lower standard activity prescribed for Graves' disease. Rigorous dosimetry will now be considered for patients with severe refractory hyperthyroidism, and thyroid function tests are now requested as routine prior to I-131 therapy. So it really was great to be able to contribute to the department as a registrar. So I'd like to finish by acknowledging my co-authors, Jung, Jeff, Paul and Dinesh, as well as James Westcott, our lead technologist, and the Royal Melbourne Nuclear Medicine Department as a whole for supporting me through last year. Thank you very much, and here are my references for your review. Thank you.